Recently, the Society for Vascular Surgery decided to put together a video library of people who were leaders of the field, innovators, and others, so that there'd be a ready access for people who were interested in seeing how vascular surgery got to where it is today. And today we have Norm Hertzer, who spent all of his professional career at the Cleveland Clinic. Welcome, Norm.
Thank you, Walter. I'm glad to be here. Thanks for the invitation.
So you were born in Toledo. Did you grow up there, or?
No, I'm told by my parents that we spent about 6 weeks there before they moved to Indiana, and I grew up in Lafayette, Indiana, college town. Folks in West Lafayette probably think they're the college town, but that's where Purdue University is. So the town has a different flavor from similar towns its size without a university. I enjoyed it very much. I had a great childhood and adolescence there.
Were your parents physicians?
No, they weren't. My mother, I had worked before I was born, but afterwards did not. My dad worked very hard. I mean, they had had their share of disappointments during the Depression and so on. And my dad worked 5 days a week in sales in northern Indiana, selling Kelly tires. And then on the weekend, he would work in a manufacturing plant in Lafayette. 3 shifts during the weekend. So he worked 7 days a week, and he wanted me to be a doctor because he thought doctors didn't work for anybody. They worked for themselves, and of course Dad didn't realize at the time that a doctor works for however many patients he happens to have at their convenience. But it was great advice, and I took it.
How did you decide about where to go to college?
As I say, my parents were of modest means, I guess. And if I went to Indiana University in Bloomington, then I could go to Indiana University Medical School after only 3 years as an undergraduate. So that was more economical, and that seemed to be important to all of us at the time, and that's what I chose to do. I missed my senior year in college, which, looking back, you wonder if you would have rather had a senior year in college, but it's so long ago now, I don't really miss it.
So there you were in medical school, and how did you ever decide you wanted to go into surgery?
I'd always wanted to be a surgeon. My dad wanted me to be a, quotes, doctor.
Mm-hmm.
When he said that, I wanted to be a surgeon. I thought that sounded more exciting. And nothing happened throughout medical school to change my mind. I probably like most surgeons, you have an opportunity to make an abrupt change in an illness, something that is not always your good fortune to be able to do when you're treating chronic medical morbidities. So I enjoyed the idea of doing something that made improved a patient quickly and virtually as soon as you had done the operation. And of course, vascular surgery was especially appropriate in that regard.
You remember any of the surgeons from Indiana when you were a medical student there that influenced you?
Hertzer Schumacher was the chairman there at the time.
Right.
And he was gorgeous. He was very skilled, of course, and he had a lot to do with the beginnings of a lot of societies, including our own. He was one of the founders, I believe, of the Society for Vascular Surgery, and wrote, excuse me, one of the, I guess the only book currently on there, on the topic of this, the development of the Society for Vascular Surgery, and I think it was published in 1984 or something like that. And he had put together the formative years in a summary. A nice book, and all members of the SDS got it. And just my memories of Hertzer Schumacher, before each surgical rotation, either on his service or when we were juniors and we were going to start our clinical services, he had this mellifluous Southern accent, very elegant Southern accent. And he would come in front of us with his white coat on the stage, and he would flip the collar up like this, and he would put his hands in his pockets, and he would address us on what was expected of us, and how we were going to grow, and how this is going to be beneficial, and so forth. But he was a very impressive presence to see when you're, 21 years old, and you think, gosh, I'm going to have to go out and see patients now, and he's going to be looking over my shoulder. He was terrific. Indiana was very proud of him, and still is.
Then you were off to the Cleveland Clinic as an intern, and did you pick from other places, or how did you get lucky enough to end up there?
It was strictly by chance. I had applied for and received a residency at the Mayo Clinic when I was in medical school. But the Mayo at that time did not have any internships. So I had to find a place to take an internship. And Marianne and I had made after we were married at the end of our sophomore year when we were juniors, and we made a trip around the country, looked at various places, and I went up to Cleveland by myself late one night after I was working as a prosector, an autopsy prosector at Methodist Hospital in Indianapolis. And I drove to Cleveland, sort of one last look at a potential place to have an internship. And I was met there the next morning by Dr. Bob Herman, who became chairman of the Department of General Surgery at that time, became second vice president of the American College of Surgeons, was a very prominent surgical traveler, and an absolutely terrific technical surgeon. And a very welcoming man when I went up there to visit. And he and I talked for about an hour, and I thought, well, boy, if they're all like this guy, I'd like to come here. That's how I went there for my internship. And after being there for 6 or 8 months, I started to ask myself, why do I want to leave? So I did not go to Mayo, even though it was very tempting, but I stayed at the clinic, and of course it influenced the rest of my life, basically. Those things happen, I'm sure, to a lot of people. Just one random event, and it sets the course for the rest of your career.
You worked under a number of prominent, busy general surgeons at the clinic, obviously, during your training. And did you ever think of being a general surgeon?
I had been invited. I was very privileged to have been invited to stay on the staff in general surgery after I completed my general surgery residency, or rather after I came back from the Army after completing my general surgery residency. I was a berry planner, and I had the option to go in the service after completing my residency, which I did. We spent 2 years at Fort Hood, Texas at that time, but I had been invited to come back on the staff in general surgery, but I wanted very much to be a vascular surgeon. So after we left the Army, I came back for, at that time, as a one-year fellowship in vascular surgery under Al Humphreys and Ed Bevan at the clinic, and ultimately was invited to join their department, and did. Did
the experience in the Army teach you anything that added to your career, or how did that all go? It was stateside.
Yeah, it was stateside. We were withdrawing at that time. The Paris Peace, I went in 72, in the summer of 72, and the Paris Peace, for whatever it was worth, was signed in December of that year. And so we were withdrawing forces. We weren't sending any forces of any kind, medical units included, to Vietnam. So Fort Hood was, it wasn't San Francisco, it wasn't Washington. They were getting the guys who had already spent a year in Nam to those more appealing geographic posts, deservedly. But Fort Hood turned out to be great. It had 2 divisions. It had the 1st Cav and the 3rd Armored, because it was a big wide open area. You can run tanks around and shoot big guns, and it didn't bother anyone. And it was a retirement area. So we had a lot of patients for a 400-bed hospital. I'll always remember one thing that happened there, and it had a nice long tennis season too, by the way, which, coming from the north, I had never enjoyed before. But I had done an aorta bifemoral bypass, and I heard from the head of the hospital, the colonel, and he was in psychiatry. He wasn't a surgeon, and he called me into his office. He said, there'll be no more of that here because the potential complication rates are too high, and we send those to Fort Sam Houston. And so I did my best, but I couldn't do any vascular surgery in the Army, but eventually did quite enough of it. So it wasn't too bad. But then after coming back to the clinic, I spent that year with Al Humphreys and Ed Bevan.
Well, tell us about Dr. Humphreys and Dr. Bevan from training with them.
Well, they're both fascinating people. The most interesting thing about Al Humphreys, and unless you're old enough to remember those times, it'll seem amazing to anyone who chooses to watch this video, but Al Humphreys was an orthopedic surgeon.
That's right.
He was not a general surgeon, a soft tissue surgeon. But Barney Kreil, who was the son of one of the 4 founders of the Cleveland Clinic, probably the most famous of the founders, George Kreil, his son George Jr., or Barney as everyone told him, called him. Barney, of course, had an enormous reputation in breast cancer and was the main spokesman for less than radical mastectomy at the time. But Barney had come back from Europe, a trip to Europe, and he told the directors at the clinic, and I'm sure the chairman of surgery and so forth, he said, you know, they're doing some pretty interesting things with arteries over there. Quinlan had done the FemPop, the original vein graft, and of course, homographs have been used for aortic replacement. I'm pretty sure that Eastcott had reported on carotid reconstruction at that time, so they were doing some interesting things over there, and they wanted a surgeon to do that. And Al got the call because basically, well, a couple of things. He had an approach, an anterior approach to the spine that required retroperitoneal mobilization and exposure of the aorta. That was one of his
So
factors.
He'd been close to the
He had
aorta
been
before.
close to the aorta before, that's
Yeah.
right, and I hope never in it,
Yeah.
under those circumstances, but close to it at least. And he had taken up angiography, percutaneous femoral angiography, just needle puncture, shoot, series of films and so forth. And in order to sort of ferret out different causes of leg pain as an orthopedic surgeon. And he had the guts of a burglar. He was a very courageous surgeon who had very courageous patients, and they decided to make Al Humphreys a vascular surgeon. He came up to Chicago here and spent about 6 months with Ormond Julian.
Oh, I see.
Who was a pioneer in vascular surgery. I hope his name is remembered. And went back to the clinic and began the Department of Vascular Surgery. Now, Ed Bevan was the best technical resident, surgical resident I think that they'd ever had there at that point, and probably to this point he is probably the best technical. He just had a gift. He was a beautiful technical surgeon even while he was training. And so he was appointed then ultimately to join Al Humphreys. And they were an interesting pair because Al was rough and tough and often a little difficult to deal with until he knew you as a resident or fellow. And if he trusted you, you were in like you were in. But before that, he kept an eye on you. Ed was the most, as anyone who knows him now can tell you, he was the most generous, thoughtful, conversational, giving person. There were none on the staff had any of those qualities any more than Ed did. I mean, he made residents feel comfortable, and he was a joy to watch. I mean, most of the things that I did, at least at the beginning, I was copying Ed.
And then along the way you got interested in carotid surgery. Were they doing that in any volume when you were being trained?
Oh yes, I mean they both had a big practice in carotid surgery. Al, and I mention this only because I've heard it is regaining favor for some reason. Al had a very limited exposure of the carotid bulb and a short incision in the bulb and sort of reached up and pulled the plaque out. And of course, carotid plaques being what they are, most of them do feather relatively well even with that, whereas Ed had a longer exposure, used a shunt more regularly, And so that at the beginning I used a shunt on all my patients. I always used general anesthesia. I never did change. Right up until the time of my retirement, I used general endotracheal anesthesia and an indwelling shunt. But about 1983, and it's interesting how surgeons, I think these things change what a surgeon does. You have an unfavorable outcome. I had a man that we were deciding whether to do a combined coronary and carotid or just have his coronaries done and then have his carotid done as a reverse stage procedure, and we chose the latter course. And he became symptomatic after his coronary bypass surgery while still in the hospital, developed a pretty serious TIA, but did not have a completed stroke. And so I went ahead and operated on him and did a primary closure. I was very happy with the operation, and he thrombosed his internal carotid artery, had a profound stroke, and ultimately I reoperated on him and did a thrombectomy that evening and put a patch on, because that's what you do if a person thromboses after a primary repair.
Sure.
Arteriotomy repair. So I thought at the time, why don't I just patch everybody? And I began to patch everyone, used vein then, and for the most part, retained a preference for vein for the rest of my practice there. And so we began to do more patching at the clinic and ultimately reported on 900 plus patients, in which those who, it was not randomized, it was an ongoing prospective study as the other members of the department started to come around to patching themselves, but we had about half patched and half not patched. And the patch group had a significantly lower risk for stroke, for early postoperative internal carotid thrombosis, and for subsequent stroke and late recurrence. And so that sold us. We patched from then on, and it was about that time that, at the time of that article was published, and thereafter came out more papers on patching and so on, and I'm pleased to see that now 75 to 80% of patients in American College of Surgeons NISQIP program and so on, and I think maybe in the Society for Vascular Surgery registry, 75 or 80% of patients now are patched. I mean, I think it should be 100%, but at least it's a lot better than when we started patching, at which time you patched only if you had a very small internal carotid artery or some technical feature that made that patient unusual.
Back in those days, there was debate about which part of the saphenous vein should be used for the patch.
Right. Right. I began by harvesting at the ankle in patients who had good saphenous veins at the ankle. I mean, you just stand them up in the office and put a tourniquet on, see how big their vein is. I want to get back to this too. Joe Archie was doing similar work at that time, and our findings were very similar to Joe's. I had one patient, again, an unfavorable outcome, who had a patch rupture.
Right.
And it was a woman in whom I'd used an ankle vein that seemed adequate in diameter at the time, but she had a rupture, and you know, she got fixed, didn't have a stroke. We put another patch on, and she ultimately turned out okay, but it was not the sort of situation any surgeon or patient wants to have happen very often. So from then on, I used the vein from the groin. And I honestly don't remember any time in patients who had it. I mean, at our place, there were a lot of patients that had previous coronary bypass surgery who did not have the saphenous vein available in the groin, but in those patients, I would use a synthetic, of course. But I don't remember any one patient, and you always remember your bad results. I don't remember any one patient who I later regretted having taken the saphenous vein from the groin because I needed it for a femtip bypass in the future and so forth. And article after article says if you need the saphenous vein for something, use it, because all these things you're saving it for may never happen. And we went, in the prosthetics, we went through the PTFE phase and all the needle hole bleeding, and you're holding her, waiting for it to stop with Sturgicel and everything on it. And then ultimately we had to use we chose to use Dacron patches rather than PTFE. But as I mentioned in my article summarizing my outcomes with carotid surgery a few years ago, I still retain a preference. If I were practicing, I'd still retain a preference for the greater saphenous vein in the groin. Those who haven't used it don't know what they're missing, but with synthetic patches on the shelf, it is so much easier that I don't think vein patching is going to sweep the nation just because of this interview, but it's a valuable resource.
Now, along the line, you became interested in the association between peripheral vascular occlusive disease and coronary disease. How did that occur to you?
Well, in simple terms, coronary artery disease was killing most of our patients, either early or late. It was the most common source of death in any peripheral vascular patient at that time. And I suspect still is in one form or the other. And I had reviewed and published late survival rates on several hundred patients who had had aortic aneurysm repair, carotid endarterectomy, or lower extremity bypass at the clinic, extending back before I was even on the staff when Humphreys and Bevan were doing it. We had late follow-up on them. And late follow-up wasn't all that common at that time. I mean, we're talking 1976, 1977, late follow-up studies. Vascular surgery then was, I'm tempted to say, almost like endovascular therapy now, and that is you had a lot of early results reported, but not very many long-term outcomes. And so I found, as I had suspected, that coronary disease was a serious problem in vascular patients in terms of not only their early mortality rate after operations, but their late survival. So I got together one afternoon with Jess Young, who was chairman of our Department of Vascular Medicine at the time, and we agreed that, you know, we really need to study this in some way. And I had suggested, I think anyone with a history of coronary artery disease in any form whatsoever, we should obtain preoperative coronary angiography before we do their aneurysm repair or their leg bypass and so on. And Jess said, I can still remember, he said, oh, well, why don't we just study them all? And so we did, at least for the next 1,400 patients, of whom we wrapped up the first 1,000 in a computer package. We were still using mainframes, of course. This is not something you just pump into a desktop. Got the computer space and whatnot and put their data in. And people say now, my gosh, you were using coronary angiography?
So you did a coronary cath on 1,400 patients consecutively to study the issue?
As consecutively as we could with respect to patient consent and all that sort of thing. People look back and they say, well, gosh. But you have to remember the only thing other than coronary angiography that we had at that time was a stress echocardiogram. I mean, we didn't have thallium, we didn't have coronary calcium scores, we didn't have Sestamibi scans or any number of things I don't even know about myself at this point for evaluation of the coronary arteries and the myocardium. And it was pretty well known then that if you do stress EKGs in a population of patients that has a high prevalence of coronary disease, you're going to have a relatively high number of false negatives. So rather than go that route, we went the coronary arteriography route. And that became a paper that stimulated a lot of interest. I mean, I knew when I was writing it, I'd probably never write anything more important. And I was, 42 or something like that. I knew it was going to be the most important thing I ever did.
When I was an intern, that paper was published, and it was quite a revelation. And now it seems so obvious to us, but people didn't recognize that at all. It was a tremendous...
It got a lot of play not only in vascular surgery
with cardiologists,
journals, but with cardiologists and with anesthesiologists, right. Preoperative risk assessment and so forth. And while not very many people end up, and of course the VA study, the CARP trial indicated at least to their satisfaction, if not to mine, that you don't have to worry about coronary artery bypass. What we were trying, what we said you had to worry about the heart. And in that era, it was the coronary arteries as evaluated by coronary angiography. In this era, it may be, well, we'll give nationally, I think, it's 75 or 80% of patients who have aortic aneurysm repair are on preoperative beta blockade. We didn't have beta blockade at that time.
That's right.
We didn't have statins. We did what we could with what we had, and I think that still translates into being careful with the heart now.
You've always been very interested in what's now called outcome research, ever since the beginning of your career, and wrote one of your presidential addresses on that. And tell us about that.
Well, first of all, I think if let's start out with the thesis, and I'm sure it's pretty solid, that most patients or surgeons in the United States really don't know what their results are. If you walked into a hospital administrator today, and certainly it was true when I became interested in this over 20 years ago, 25 years ago, and ask him, okay, George, what is the operative mortality rate for aortic aneurysm repair over the past 2 years in your hospital? He wouldn't have a clue. And yet I think, by the same token, I think most patients think that their surgeon or their hospital know what their results are. So that there's really a mismatch here. And the Cleveland Vascular Society started to address this sort of thing. The Cleveland Vascular Society was a sort of a joint idea of Al Humphreys among the, quotes, academic vascular surgeons in town. And also Ralph De Palma. At that time he was at Western Reserve University Medical School. And a community surgeon who was a very endearing guy named Joe Avalone. He worked on the west side of town and at Lutheran Hospital, and they put their heads together and got a grant, very importantly, from the Cleveland Foundation, a seed money from the Cleveland Foundation, and started the Cleveland Vascular Registry. Now, the seed money was important because it gave them mainframe access, which at that time was, you had to go out and purchase. And it also gave them a full-time registry secretary who would go to the various hospitals and represented by the surgeons and members of the Cleveland Vascular Society, and would make sure that all their cases had in fact been entered, because compliance is important. You have to have consecutive cases, because you can't just have surgeons leaving out their bad results and then reporting only their good ones. I mean, that's phony. So we had a registry secretary who would document those things. And as a matter of fact, the second paper reported in the Journal of Vascular Surgery, it was 1984, I think, and it was a paper that I presented on behalf of the Cleveland Vascular Society with respect to the risk of various types of vascular surgery, aortic aneurysms, lower extremity bypass, and carotid endarterectomy in a metropolitan community. And it's the second paper in the first issue of the journal. And it showed that volume made a difference at both the hospital and surgeon level. There was a lower mortality rate in high volume whichevers for aortic aneurysm repair, and there was a lower amputation rate for high volume surgeons and hospitals with respect to lower extremity bypass. And it only makes sense. I don't know whether good surgeons get busy or busy surgeons get good, but I mean, the more cases you've done, you're like a Major League Baseball player. The more games you've played, the more likely you are to get a hit.
That's right. That's right. Well, then, what about a national? Tell us, what about a national database for vascular surgery? The Society for Thoracic Surgery has a database that's been established for about 15 years now and has a lot of data in it. Who would pay for that? How should that be done?
Well, I had a couple ideas on that. When Medicare reimbursement reform came steaming around the corner in the late 80s and early 90s, and I happened to be secretary of the Society for Vascular Surgery at that time, and was, because of that position, right in the headlights. I started to think, how can we make something good out of this? Because it was obviously as we looked at it then, I don't see any reason to change the opinion now. We thought that the Medicare reimbursement reform was going to take reimbursement from the surgeons and redistribute it to the internists. And that was the reason that the American Medical Association was soundly behind it. And whether that was the right or wrong thing to do, I'm not being judgmental about that. But it was a redistribution issue. And I thought, how can we take this issue and make it better? So my idea was to link outcome assessment, make it a requirement for hospitals that are getting Medicare reimbursement. Make that one of the boxes they have to check off. Because at that time we had PCs. By that time you didn't have to buy mainframe space. By that time every hospital had more clerical people doing other things than they needed and could easily devote someone to entering data into a database so that they would know their own results. I'd actually, and I'm mentioning this only because Jim, who's seated here with us at the end of the table, might remember in 1988 I had proposed this to the Society for Vascular Surgery. Cal Ernst had organized what eventually became the first critical issues forum to be held before the Society for Vascular Surgery, and they asked me to talk about this because I had addressed it in the presidential address to the Midwestern a year or two before. And I proposed that the SVS develop a registry to set a benchmark for what these hospitals that I thought should be recording their own results, should be documenting them, what their benchmark, what their target should be. That is, the results of the Society for Vascular Surgery. Because I thought we could establish a target level of complications that should be accomplished by most hospitals, at least let them know what that target was, and no one knew what it was at that time, but no action was taken on it at that point. So to make the transition to the present time, I think it is terrific that I know Jack Cronenwes is behind this to some extent. I don't know whether he is the motivating force or one of many motivating forces in the current Society for Vascular Surgery project regarding outcome assessment. Quality Initiative Project, I think, of the Society for Vascular Surgery. And it is developing a registry, modeled, I'm sure, substantially after the study group of Northern New England, now the Vascular Study Group of New England. They've expanded, so it's not only Northern anymore.
Which is set up as cells in different areas, but it's not inclusive by some mandate.
Right, no, that's right. As a matter of fact, I believe Jack and those working closely with him on this want to have regional groups that are working on this.
Correct.
Certainly Dan Clare at the Cleveland Clinic is organizing now one in Ohio.
There's one in Chicago, and there's one in Charleston, and there are areas where it's prominent, but it doesn't encompass the whole country.
No, right, but I hope that someday it will, because it seems to make, I don't know how one can argue that it is not a good thing to do.
Back in the early 1980s, the Society for Vascular Surgery set up a traveling fellowship named after Dr. Wiley. It was an idea of Jim Yao and John Bergen and Jack Hoover and Don Lass, and they ended up modeling it after the James IV Traveling Fellowship, which you did. So tell us how that all went and how you got that fellowship.
Well, it was 1984, and Dr. Bob Herman, who was the man I met when I first went to look at an internship at the Cleveland Clinic, and I've mentioned is a fantastic technical surgeon. Bob was a member of the James IV Association. I don't know if he had been a traveler himself. I don't recall that. I think he had received travelers. He'd been a host of travelers here. And is now one of my golfing buddies, by the way. Bob is. But he nominated me, and I'd written enough that I guess they thought it was okay, and they appointed me as a James IV traveler. And you could go anywhere in the world, but I was from Indiana, and I wasn't about to go any place where they didn't speak my language. So I went to Scotland and made several stops by train all the way down to London, where I would stop in a place and give a talk, and then listen to residents present their papers or make rounds with the residents in the afternoon. And then that evening, maybe give another talk or be the reason for a party for their department that night, and then the next morning hop on the train and be on my way again. And it was very interesting, and as you and I were mentioning, I was telling you a few minutes ago, one of the surprises on this trip was when I was still up in Ireland before getting down to England. It was a weekend, and my host said, "Would you like to play golf?" And I hadn't played golf since I was a teenager. I hacked around with my buddies in a golf course, a Muni golf course. I can still remember that if you hit it too far to the right, you're in a cornfield. So that was Indiana. So that was my level of golf. I said, "Well, Jay, I don't have any clubs." He said, "I've got clubs." "I don't have any shoes." "Well, I've got shoes." So he arranged to pick me up Saturday morning. He said, "One thing, bring a tie." I said, "That's unusual." And I didn't know where we were going, and he takes me to the Royal and Ancient at St. Andrews. So I play golf at the Royal and Ancient. The guy that, favorite shot was a duck hook at the time, if and when I ever played. And we get there, and the Open was to be held there a couple of weeks later. And they were building the grandstands and whatnot. And my host comes out from the caddy area there, or a group of very stern Scotchmen in caps and sport coats were watching sternly. He said, "Oh, I'm sorry to tell you that the caddy master tells me because the Open's going to be held here in 2 weeks, we have to tee up our fairway lies." And I thought, thank God, because it was the only thing that saved me. But it was a great trip. I enjoyed meeting a lot of people. Felix E. Scott was a terrific host in London. Got to know him and his wife better. My daughter Lisa, who had just graduated from college, she was from high school, she was about to enter college, she could speak French, fortunately, and she joined me in London, and we went to Paris with Edouard Kiefer, who was our host there, a generous and terrific host and a terrific surgeon. And then we went to Munich, and it was a wonderful trip. I enjoyed every minute of it.
Tell us about some of your surgical heroes looking back over your career and people that inspired you from other places besides those who trained you.
Yeah, well, I have a core of fellows that inspired me tremendously. Ed Bevan and Bob Herman were certainly the ones closest to home. Most impressively to me, they were really terrific surgeons who made operations look easier difficult operations look easy by setting them up so well. I mean, their exposure was terrific, so that by the time they got to the heart of the issue, it looked easy because they weren't reaching around things, they weren't trying to reach under things or looking over things. They could see everything clearly, and I tried to do the same thing myself. Nationally, anyone who was practicing vascular surgery at that time that doesn't believe that doesn't hold Stan Crawford as one of his heroes must have been looking the other way, because when you start reporting on 1,300 or 1,500 thoracoabdominal aortic aneurysm repairs. That draws your attention. And I once, once I'd gotten to know him, I asked him if he would have his secretary call me the next time he had 3 or 4 of them set up for any 2-day period, and I would drop everything and fly down and see him operate, which I did. He called and I went, and he never wasted a move. I mean, he wasn't especially fast, and I'd seen this with good surgeons at the clinic. He wasn't slow, by the way, but he wasn't just lickety-split fast. He just never had to repeat anything. He started a day and he finished at Z, and he didn't have to go take a step backward anywhere along the line. I'm very impressed with him. And although I'd never seen the other surgeon I'm going to mention operate, intellectually I thought he was very, very impressive, just absolutely at the top of the game, and that was Emmerich Zalagi. Anyone who knew Emmerich and remembers being active in vascular surgery at that time knows that he could be a very stern taskmaster if you presented a paper in his presence and he didn't think it was logical.
And an editor, too.
Yeah, well, absolutely. Yeah, oh, absolutely. I'll get to that in a second. But if you pleased him, you knew that you'd really accomplished something. Or at least you thought you'd really accomplished something. I mean, you had to assume that he was correct in order to know that you had accomplished something, but I mean, you thought that you had accomplished something. And he asked me to be an associate editor of the journal in 1988 or 9, and I, of course, jumped at the opportunity. I was very pleased, proud, privileged that he would even think of me. And I got to work with him more closely, and those who submit articles to any journal now can appreciate the difference here, but Emmerich would have his associate editors who happened to be, in addition, I was a junior associate editor, and Cal Ernst and Jim Stanley had been on his staff for some years before that. But Emmerich would send any article that was submitted out to reviewers, but he would also assign it to one of us, and we would have to review it also, and we would have to review the reviews. Because you know, the reviews aren't always right. You know, the people who review it may miss the boat or not devote enough time to it, or not really just send in a couple comments that don't really apply to the important deficits in the paper. So they had to be edited by the associate editors, and then we would send Emmerich our overall assessment. And then he would write the author a letter, a personal letter, not in handwriting, it was typed, of course, but I mean, he would dictate it, or however he did that. It was not a form letter. Every author's got a different letter, which is not particularly the case now, and not just with respect to the JVS that I hold in the Journal of Vascular Surgery, which I hold in the highest esteem and respect, but it's just the way things are done now. You get a form letter back with the review comments. You got a letter from the editor, from Emmerich Zalagi, and if it was a long letter, it was not. You had a lot of work to do. Things didn't always turn out well. If it was a long letter, if it was a short letter, it's like a college acceptance. You know, I mean, that's fine. But he was a marvelous guy, a terrific intellect, and he maintained that level for a long, long time.
One of the problems that we have now teaching vascular fellows is how to teach them to do open operations. Do you have any? They're all getting quite good at endo, but they're not as good at open operations, which probably are harder to do.
I'm glad you said that.
Any advice for us?
I sure agree with you. I look back sometimes and look at the things that they're doing wonderful work on using catheter-based intervention now. And I think it's wonderful, and it's just in time for people like Jim Yao and me, of course. You know, we've got these catheter-based interventions that we can get the benefit from if we need them. I hope that because of this, people don't start losing track of the verities, which are the one that jumps into my mind. Use the saphenous vein whenever you can. Don't just jump to a synthetic. I see more articles, and I hope that they mostly address patients who do not have autogenous vein available, either in the leg or the arm. But I see more articles in various synthetics now. They're heparin impregnated and so forth, and that's supposed to be better. But young surgeons for whom open operations are the minority of cases they've seen in their fellowship, don't forget to use the saphenous vein. Don't just leave it behind.
Do you have some general advice for young surgeons that are going into vascular now? Career-wise or?
One thing comes to mind, something that I've thought about with these handheld smartphones and data sources. I mean, you can put an Excel spreadsheet on your phone now. And with respect to keeping track of your own results, what could be easier than to have your data set on your phone? You have the name of the patient in because you did the operation. You put that in at the time of the operation. When they left the hospital, you remarked on whether they had a stroke or not, or whether they had some complication. You could have categories A to Z and complications separately from your phone if you want. And then when you saw them in the office, you go out in the hallway, you enter the follow-up, and you've got it. Personal computers certainly made that easier than mainframes, but all the new technology, such as the smartphone now, and these handheld devices, would make it very easy. I think that you should keep track of your own results.
We were talking earlier about Juan Perotti, and you were fellows together.
Yeah, we were. Juan
at the clinic.
Dr. Humphreys always liked to have we had two fellows, and it was a one-year program. He liked to have them 6 months out of sync because he never wanted to wake up in the morning and have nobody know nothing. He wanted somebody who'd been there for 6 months. And so I started in July after leaving the service and leaving Fort Hood, and was with a fellow named Tom Corrigan from Ireland, who's made quite a name for himself in Ireland as an author and surgeon. And the fellow who replaced Tom, beginning the 1st of January then, was Juan Perotti. And Juan was a charming guy. I mean, we had several former fellows from South America, and anyone who knows these kinds of people, they see your children, they run up and give them a kiss. They're just so emotive. They're just so pleasant. And Juan and his wife were no exception. And we got along very well. And when I left then, I went to practice in Indiana for 1 year before I was invited back to be in the Department of Vascular Surgery. And Juan had by that time left after completed his training there.
So Juan Perotti had gone back home by the time you got to the clinic, and Ed Bevan did keep in touch with him.
He did, because they were both involved, I'm sure, in it's an international society for Spanish-speaking surgeons. And Ed, when we found out through some of their mutual friends, or maybe Ed found out from Juan himself, in the mid-'80s, that he was working on this process. He had this idea of replacing aortic aneurysms from the inside somehow over a wire. We said, that idea is never going to work. What's Juan talking about? And of course it revolutionized and rejuvenated a field. I mean, vascular surgery and the Society for Vascular Surgery and the annual meetings and the Journal of Vascular Surgery were rejuvenated by the endovascular explosion.
Tell us a bit about your family.
Well, I'm very proud of my family. Mary Ann and I, we met in college, my wife Mary Ann, and we met when we were sophomores in college, and we've been married now for 47 years. We have 3 kids. Our older daughter Lisa went to Stanford, undergrad in Harvard Law, and is until recently was a practicing attorney in the U.S. Attorney's Office and Department of Justice. Eventually was on the staff in the Solicitor General's office pleading cases before the Supreme Court. And if you think you're not proud when you go to a court session and see your daughter pleading a case before it, I mean, that was really special. She is married to an attorney there and now does appellate work for Dave Shirtler's office, her husband, because she has young boys, teenagers now, that require her presence at home. My son John went to Tufts University in his undergraduate, and then the Medical College of Ohio, and trained in Washington, D.C., where he met his wife, Julie, and is now the interim chairman of the Department of Child and Adolescent Psychiatry at Case Western Reserve University School of Medicine in Cleveland, and enjoys living there very much. And our daughter, Brooke, our youngest, 10 years separated from John and Lisa, went to Stanford, also like Lisa, went to University of Virginia Law School, and was an attorney in Philadelphia before she met Michael McDermott, her husband, and she is now taking care of their 2, soon-to-be 3 boys. So we have a total of 6 going on 7 grandkids, and we're all very close, although we live a distance from each other for the most part. And I'm, like I hope everyone, very proud of my family.
Do you have any hobbies or other interests that are keeping you busy at the moment besides golf?
Well, I still write, you know. I'm still, I've been fortunate. I have enough data to retire with that I've written, 10 or 12 original articles and or book chapters since retiring about 7 years ago. I must say I write better in Cleveland because there are too many distractions in Georgia. We also have a home in Georgia, about halfway between Atlanta and Augusta, that is really golf country. And we live on a course, and one of the photographs that you'll see as part of this video presentation interview shows me preparing to miss a short putt on the green just behind my house. I don't write very well down there because there's just too many other things to do. But while in Cleveland, we have a smaller place in Cleveland. And when in Cleveland, I do like to write. You know, Walter, I used to play tennis, but I just found that after a certain age, I was just going to get worse at tennis, and I still had a chance. At this age, you don't have an opportunity to get better at very many things. Most of the things you were going to get better at, they're in your past. But golf, I think there's always a prayer, if not a real good chance. And tennis, it was just not going to turn out real well.
Well, Norm, thank you very much. I've really enjoyed this, and this will be very interesting for people to look through in the future.
Walter, I did too. Thanks very much.